we start with Dr. Nawalanic?
Oh, great.
Yeah, introduce yourself. You're new to the panel.
All right, good morning, everybody. This is Gregory Nawalanic. I'm a clinical psychologist with the health system, and I'm here to speak about the importance of just trying to remain calm, remain focused on doing all that we can to empower ourselves so that we can be less panicked and more in control and move safely through this situation.
Steve Stites, Chief Medical Officer here. My whole commentary this morning will be focused around the same things we talked a little bit about yesterday. There's a lot of fear. You have to channel your fear and realize your FOD, fear of doorknobs, has to overcome the DOD, the danger of doorknobs. And those are really placeholders, really, right, for making sure you're doing the right thing about cleaning surfaces, washing your hands, and keeping your distance and staying home, because those are the things we know that blunt the curve. It is unquestionably true. You save lives, you stay healthier if you maintain your FOD and watch out for the DOD.
This is Dana Hawkinson, infectious disease physician and medical director of infection prevention and control. And I'm just going to continue to relay my underlying messages of adequate hand hygiene, staying home if you're sick, not touching your face to your hands. You know, it's very difficult. That is something we do every day. 20 times, 50 times an hour. It's very difficult. I know when I was even at Target last night, when I got an itch in the middle of my shopping, it was very difficult not to do that. And I actually had to wait till I got home, was able to wash my hands. But we get those little instances every day where we're just touching our face and we don't even realize it. And you know, as I see more and more patients in the hospital and I'm treating them, it is more and more evident to me that the communication of this disease is really basically, you know, not hand to mouth, but hand to face. And if we can continue to do adequate hand hygiene and keep our hands away from our face as much as possible, I think we will really be able to stop the spread to a great degree.
So wrapping in there, you know, where we stand in terms of why.
Hey, you guys, we're ready to take questions. Please mute your line if you're not wanting to, unless you've got music. We don't want music playing, but I think the doctors are open to taking your questions now.
Okay, this is Dale Hogg at the Great Bend Tribune.
Yes, sir. Go ahead.
Okay, I understand according to your email that came out this morning, you guys are doing testing for the COVID-19 at your University of Kansas Health System's facilities?
Yes, we are.
Is that all, even like out here in Great Bend and the Great Bend campus and so on?
So at this point, the testing is new. We started it late Sunday into Monday. It is our own equipment in here. We can only do a certain amount during the day. So to this point, we have not been bringing tests back, but we anticipate our ability to do that in the very near future.
So just to clarify, then you're not conducting tests at the local facilities then?
No, the testing is only, right, the testing's here in Kansas City, Kansas at our main hospital. Okay. The equipment's pretty large and it's not easily mobile.
Gotcha.
We are exploring what that means for Great Bend, Hayes, and other places and whether or not we can handle those tests. Our first deal is to try and test as many inpatients as possible who are rule-outs, because what happens when you're in the hospital and you're made a COVID rule-out, then we put you in all the advanced infection control precautions. We burn through that equipment really fast. And so we don't, if we can get that test result back faster, we can take you out of those infection control things. So that's really the focus of our testing right now, is to get any inpatients done so we don't burn through our infection control and our protective equipment. Because we know that there's going to be more COVID-19 cases coming, and we want to make sure we maintain as much of that equipment as we can.
Okay.
Hi there, this is Kat Reed with 41 Action News. I have another question about testing. You know, we've covered a lot of stories about COVID-19 testing being free. I was curious if at this point it is being offered for free to patients at KU Hospital and University of Kansas Hospital, and also how you guys what you know at this point about how you'll be reimbursed potentially for the testing.
Well, what we know is that when we send it to a private lab, the testing runs between $200 and $500. Medicare fee schedule pays us $35. There is that statement that in some of the things from the government, federal government, that it will be free. That is not something that has occurred for us currently.
So this is a burden on the system. It's not a cheap testing for you guys to be fronting these costs.
Right. There's nothing about COVID-19 that is cheap. We've had to cancel elective surgeries. We've had to cancel our ambulatory clinics, all to preserve our infectious equipment, our PPE. And so COVID-19 is really, really hard on healthcare here at KU, in Kansas City, and throughout the country because it significantly affects your revenue and increases your costs.
This is Steve Baccarat with the Kansas City Star, and to jump off of the testing question, can you explain on a local or regional hospital system standpoint the difficulty and why it's been slow to obtain sufficient testing supplies, and address the extent to which that's affected one way or another the hospital system's ability to cope with COVID-19?
Yeah, I can tell you what our situation is. I can't speak to other health systems, but the shortage was because there simply weren't enough testing kits available, and then if you had testing kits, then you had a very long delay in getting results. At one point, we were waiting 4 to 5 days to get test results. The impact of that is we had a number of, if you heard the news conference yesterday, I think the president of the Kansas City campus, Tammy Peterman, pointed out that I believe we had about 42 patients in hospital beds waiting for a rule-out diagnosis, meaning that they were admitted for evaluation of some health problem, and part of that we had to check for COVID-19. That's the COVID-19 parts that what puts them into infectious precautions. And so when you start doing that, you have to wear all the equipment. That's equipment that then you burn through and you can't use. A lot of it's disposable, and because it's, it can be contaminated. And so what then happens is you can't preserve that equipment for the real patient who does come in with it. So this patient sitting in our hospital for 3, 4, 5 days waiting on the results of a test, that was a huge limiting factor. Now that has gotten better. And that's why we've tried to push so hard to have in-house testing. But it's still, we are waiting on patients who were several days delayed back before we had our own internal test. And that's the struggle for everybody. And I think everybody will tell you that that's a problem for us. So.
Hey, Dr. Stites, this is Dr. Stites, right? I got in kind of late.
I'm Steve Stites. Dana Hawkinson's here, as well as Gregory Nawalanic. I think I said that correctly.
So you guys, this is Mike Sherry at KHPT. I kind of got in late, but to your point, Dr. Stites, about having to sort of hold a lot of the ambulatory, a lot of the things. I mean, how much of that can you address through telemedicine? I mean, I know you guys you mentioned trying to ramp that up.
You bet.
But
yeah.
So how much of those reimbursable non-COVID-19 procedures can you do through telemedicine?
Well, procedures you can't do very well.
Well, right, not procedures.
But I know, I'm just messing here. But the patient visits, yes. And so a couple of thoughts. First, cancer patients have to still come get their care, right? There are some patients who just have to come and be seen. And so we don't want everybody canceling, and we don't want to delay surgeries for critical time-sensitive diagnoses like cancer. So we're still doing that body of work. So our ambulatory visits are down significantly, but they're not all the way gone, and we still have a surgical schedule that is running. It's just markedly diminished from where it normally is. Those are all time-sensitive cases. We need to do those, and we're going to do them. Because we're not going to, we don't want to put anybody's life in jeopardy, either with COVID-19 or those without it, and have all their other health problems that continue. Now, the ones who we think are a little more elective, we will reach out, and we believe within the next few weeks, we'll be able to, within the next 2 weeks, we think almost every one of our patients can receive a telemedicine visit, which is a remarkable statement. Having said that, remember that part of the story is that, that we are ramping it up now. So it started last week we started doing telemedicine. We have a COVID-19 follow-up clinic for patients who are at home of ours who have been diagnosed with COVID-19, and we reach out to them with telemedicine. We have a clinic that in our primary care offices and other places have started with that. We're all getting in service this week. We think within 2 weeks, all of our clinic visits can be done by telemedicine. That doesn't mean it's the best alternative, but it means that it's better than no alternative. And so that's kind of been our philosophy as far as reimbursement goes. We're told that those are going to reimburse close to what a clinic visit is, but that's, we haven't seen any of that yet, and that is still being discussed.
Thank you.
This is Kat Reed with 41 Action News again. I have a question just because there have been a lot of stories recently about the cruise where COVID-19 kind of ran rampant. And I was curious if you could just reiterate or address how long at this point we believe the virus can live on surfaces.
Yeah, that's still a great question. Again, we don't have a lot of evidence. People will have opinions about the article that was published in New England Journal of Medicine about that. I think it was a good article, but we have to take into consideration the caveats with that. It was a very pristine laboratory environment. I think overall it allows us to show and know that certainly the virus can live on surfaces or can be detected in a certain amount of time, whether it's a few hours to a few days, but when you get out to a few days, and certainly in the normal environment, the virus is probably going to break down. So we do believe that there is indirect spread of this virus, meaning it can be on surfaces and people can pick it up, especially because a lot of people don't have any known contact with any specific sick patients or have any known contact with people who are either coughing close to them or in their face. Or sneezing close to them or in their face. So we know that there is indirect spread. But how long can it live? Probably out in the environment. I wouldn't say based on that article, certainly that shows a few hours depending on what surface it is. But then as you get outside and in the sunlight and in the different humidity ranges, it's probably not that long. But again, we do know that there is evidence of indirect spread. So it is living on there for a little bit, and other people are able to pick it up and most likely infect themselves by touching their face, their eyes, their nose, or mouth.
Got it. And we have gotten a couple questions from viewers who are making the essential trips to the grocery store. Mm-hmm. Do they need to be wiping down items when they get back to their home? Like their milk that they grabbed and things like that before putting them up?
Yeah, and that's, different experts are weighing in on their opinions. I think it's not a bad idea to, be washing your fruits and your vegetables. Certainly wiping down those surfaces of those milk containers or cans or anything is not a bad idea. We haven't shown any proven transmission through those, but again, we know that it can live on surfaces for a few hours. You don't know if someone came in before you and was ill. The other thing I would advise is, again, if you have alcohol gel, if there's some available to you, after you get out of the store, wipe your hands down. Or when you get home, as soon as you're doing everything, wash your hands. And at those times, in those cases, then certainly it's not unreasonable to wipe down your new grocery containers, such as milk and cans and things like that. Again, with all the unknowns with this, there are a lot of experts weighing in, and that seems like a reasonable thing to do. So I think, if you'd like to do that, I don't think it's a bad idea.
Hello, this is Mike from KCT again. I mean, the Surgeon General has said that, this next week is going to be bad. Do you guys, I know this is kind of a tough question, but do you know how long it might take to see a spike here in the region and when we might be able to flatten the curve?
Well, we won't know. We think that we are seeing an increased number of cases. It's not overwhelming right now. We think we're 2 to 3 weeks away from really accelerating into that. It will take us 2 to 4 to 6 weeks to see what we've really done to the curve. And that's because if you get sick now, you won't really know until at least 7 to 14 days after that how many of those people need critical care. And that's when you're in the accelerating part, and then they're getting in contact with others, and they're in contact with others yet. That's why it takes a while to see if we've really flattened the curve. Flattening the curve is not a short-term game, just to be clear about that, right? If you flatten the curve, and there's, oh, we flattened the curve, let's run out and party, well, you know, then the curve's not flat anymore. And so that's really the struggle, and we have to figure out how society adapts to that. And I'm not a politico. I just can tell you the medical part of this and say that you know, flattening the curve is a commitment. It's not a short-term fix.
Dr. Nawalanic, can you speak to the anxiety
Bill,
you might feel?
You know, one of the questions that we're hearing is about the anxiety that people feel. Dr. Nawalanic, thoughts about that?
You know, I think that all the information that keeps coming out and being updated, it keeps people kind of on edge, and the fact that there isn't a systemic, I guess I'm being asked for you guys to mute the line, sorry. So I guess that since there isn't really a systemic nationwide solution to this and that it's kind of rolling area by area, it tends to heighten people's anxiety, and it's okay to be anxious in this time. This is an unprecedented, kind of uncharted territory that we're in. But as long as everybody is doing everything that they can, it gives us the opportunity to exercise some modicum of control over an otherwise unknown situation. So, you know, canceling those trips, staying home, trying to kind of hunker down and ride through this, avoiding contact with your face, with your hands, all the things that the experts have recommended. We're only as strong as our weakest link. So I think that the best encouragement I can give is don't be that weak link, and then that's the sooner that we can move past this. So it's going to
less toll on your emotional health in the long run, right?
100%.
I mean, it's hard in the short run, but in the long run, if your loved ones and you are healthy, you know, okay, let's go.
Yeah, and the idea is that the more sacrifices that we can make now in the short term and flatten the curve like Dr. Stites was talking about, the shorter that this, and by short it's a relative term of course, but the sooner that we can move past this, rather than if we're continuing to take vacations or road trips or do whatever we feel we need to do for ourselves, we need to start thinking more as a collectivist culture rather than an individual. And that can be a real challenge for Americans, but it's something that I know that we can rise to. And there was, you know, someone speaking this morning about, you know, nobody's being asked to go to war. We're literally being asked to sit home and kind of couch surf. So if we can look at it that way and look at the opportunities that are out there, you know, the guitar manufacturer Fender is offering free lessons for 3 months for people, which is really impressive. So, I mean, a lot of people have these great ideas of things that they want to do but never have time. And there might be some anxiety around that because it's time to call bluffs and say, hey, you've got the time, what are you going to do?
We got to support our local folks. You know, my wife and I enjoy Brookside Poultry. Some great fried chicken out there, and this Saturday we decided we were going to go splurge and have some, and we did the curbside pickup. And so, how's business? He's like, it's never been better. You know, it's people adapting to the circumstance that they're in to try and turn that for a win. And for some groups, that's easier than others. But here's how I would say it about that time question. I was trying to think, how can I explain this better? Okay, it's a football game, and we're the Chiefs. It's the first quarter. We've gotten the opening kickoff. We've got one first down because we did early shelter at home. Guys, we're way ahead of other areas for that. That's really good. So we got a first down. But you got to keep the drive alive. New York, they're in the second quarter, right? They're not even to halftime yet. That's where we are. And so we just have to keep the drive alive.
Hey, Dr. Dennis Boone over at Ingram. We've heard a lot about the whole concept of flattening the curve, but I don't think there's a public mechanism that tells us how strained the medical resources are. Is there any way to know how beds are filling up as a result of admissions?
Well, we keep track of that every day, and again, we talked about that yesterday. I think that, again, you're early in the first quarter, and so beds are not a problem in Kansas City. Beds are a big problem in New York City, okay? Which is why you're flattening the curve, and we're hoping that between that and our, you know, we have a lot less population density here. We're hoping that plays in our favor. We're hoping the time of it plays in our favor around the seasonality of normal coronaviruses. There are things to make us have some hope. But you're in the first quarter. You've got the opening kickoff. You've got one first down. There's a lot of game left.
Hey guys,
One quick question.
It's Cynthia Newsom calling with 41 Action News. Hey, I just have a question about cancer patients and how we're told, we're one of the at-risk categories, so we need to keep our immune system kind of ramped up. How do we do that? What are some suggestions? How can cancer patients try to protect themselves better?
I think that's a good multimodal question and with multiple answers. I'll start, and I think that's very good. There are just natural things that we can do to help prime and keep our immune system primed. Eating healthy, nutrition is vitally important. Exercise, physical activity is important, and those are things that we can do now. Certainly. You're welcome to take over-the-counter vitamins and things of that nature, but I think certainly nutrition and physical exercise is important, keeping active. And I think the second thing is sleep and emotional health. And certainly correct me if I'm wrong, and I'll let you take the lead on that, but I think sleep is restorative for those kinds of things too. Now, it's sometimes difficult to get sleep in this day and age with this going on, but I'd like to turn it over to Dr. Nawalanic.
Yeah, the tips that we give to our patients around this are that we want to be getting outside for some time of every day if we can, getting a little exercise, even if it's just taking a walk. And I spoke with somebody this morning on a support call that we had that they're scared to go outside and walk because people come the other way. And I said, you can actually cross the street, you can walk around, you can go up on a hill. You don't have to stay in contact with everybody that you pass on the sidewalk. So, and the exercise serves a number of things. It boosts our immune system, it releases endorphins, makes us feel better, and then that also supports immune response. And then the big plus of that is that also if you're outside exercising during the day a little bit, you'll probably be a little more tired at the end of the day and able to wind down more effectively and get that restful sleep that we're looking to get. The problem is that a lot of folks are turning on the TV, watching the nightly news, and they're, or even, God forbid, they hit the 24-hour news cycle and they're just gobbling every bit before they go to bed. Then you've kind of set yourself up for failure because first of all, screens are very activating. So the best advice we can give is turn off all the screens, the phones, the iPads, the laptops, the email, the news, any of it, an hour before your intended actual bedtime. And you'd say, what do I do in that last hour before bed? You can try reading a book. That worked for years for people. You can also talk to one another. If you've got kids, spend time with them. Obviously, you're going to bed probably after them, but even for them, make sure that they're not having screen time right before bed so that they can wind down. Their little brains can kind of chill out and they can get some better sleep. Right now is a difficult time for them, a lot of uncertainty, and so I know that it's exciting for us to have time home with our kids now. I'm telling you that. But it's the reality is that they're going to be activated, and the more calm and present that you can be and acknowledge that their behavioral outbursts and things are them trying to explain that they're uncomfortable. They don't have the words to express it, so you're going to see a lot of behavioral acting out. And so just accept that that's kind of the new normal for a little bit, and that the more calm, patient, and reassuring you can be with them, the better they're going to be, the sooner they're going to be able to go to bed, which will give you a little more of your own self-time so that you can do the self-care activities that you want to do to calm yourself before going to bed, because that restful sleep is really one of the best tools that we have to keep our immune function up.
Maybe my wife will believe that that's why I act out. I'm going to try that and see how that works for me.
Go for it.
Hey, Dr. Stites, this is Mike again with KCT. You mentioned the financial burden. I mean, I know that's not first and foremost, but how much of a financial burden is this putting on a system? And I don't know, they're talking about a $2 trillion stimulus. Does anybody know if there's any relief for hospitals in there?
So Senator Moran last night said he had hoped there would be a $75 billion for hospitals or health systems, and I don't know how that got earmarked. I don't know if it's in the most recent, I don't know where it is, but that's the number that we've heard kicked around. I don't know about that. We're so early in the crisis in Kansas City that it's a little hard to really quantify it, and we don't know the impact of what, we don't know how much for sure we're going to get paid on COVID-19 cases. So it's really hard. What we know is that when you cancel your engines of a clinic, I mean, what drives your revenue? Well, it's doing stuff, and not unnecessary stuff, but being able to offer and take care of your patients, and by reducing OR capacity by a huge percentage and reducing your ambulatory claims by a huge percentage, those are two of your biggest revenue producers, and so those hurt you. We do it because it's the right thing to do, right? It's the right thing to do because we have to preserve the PPE to keep people safe. So it is the right thing to do. But it's a really hard thing to do because in the long run you have to stay viable because we got to take care of everybody. And it's not just us. Every hospital and health system in Kansas City is thinking the same thing. And we did that without any knowledge of what, and I say we, I mean all of us, all of the hospitals that have done this. We did that without any knowledge of what could come from the federal government or any other sources. And we do it because it's the right thing.
Hey, this is Matt Slinger. Yeah, this is Matt Slinger from KNBC. I'm working on a story about chloroquine and hydroxychloroquine today. With the talk from the president over the past few days about this. I've got a couple of questions regarding this. Number one, have you guys seen an increase in demand for these? So with azithromycin, and then what types of advice are you guys giving to your providers and your pharmacists regarding these drugs? And then I have one more follow-up question after that.
So, Dana, you want to take the question
Sure.
about, or how's it getting used, and I can help field the question about the demand on the pharmacy.
Yeah, I think anecdotally, we have certainly locally, from what I have heard, there has been an increased demand. Here at the health system, we do have certain criteria in place to put patients on it if they meet that criteria. Now, again, we need to stress that these are not benign drugs. There are still people who are really sick with conditions for which they are approved and need these drugs. And these drugs have never had proven efficacy. There are a lot of studies out there, but those studies have a lot of caveats and have been identified as having so. Now, we don't have anything else, and so it's hard for us as medical professionals to sit and do nothing. So we are using these drugs in a very regimented manner in patients who meet certain criteria who we think that it would offer the most benefit, again, because they are not benign. There are patients who actually need these drugs for medical diagnoses for which they're approved. And so based on that, that is how and why we're using them for our patients here at the health system.
And just to follow up, that we've had calls from patients, they get a cold, they get a little of a runny nose and a sneeze, and they want to go on hydroxychloroquine, which is Plaquenil. And we're like, no, that's not the indication. You have to be sick or you have to be in the hospital, and we do have it on a research protocol so we can look at it in a way that makes sense and not just we're handing it out. There has been an increased demand. We've said no to those, and we are not writing routine prescriptions unless you are already on it for hydroxychloroquine, and we're asking providers to think of alternatives to a Z-Pak so we can conserve azithromycin for our sickest folks.
Got it. And thanks for those answers. I appreciate it. So the follow-up question for that would be, I guess, so the guidance is you're not prescribing it right now for COVID-19 patients. And then the other question I would have is, how important is the clinical trial process in this, and maybe what does that process look like?
So it's not true that we aren't. We are prescribing for our patients in the hospital, yes, but it's under strict criteria. And those criteria are based on other studies which have been done as well to evaluate, the patients that need it the most.
Coming out of China, France, Italy, and
Correct.
other places that have had this and that they've started talking about it.
And what was the second question about the trials?
Sorry, I apologize for all the questions. So how important is the clinical trial process in this when it comes to, prescribing for COVID-19, and what does that process even look like?
Yeah, the trial process in general for any medicine is very important. We have to look at safety. We need to make sure that the medicine we're giving you isn't going to make you more sick, isn't going to bring about deleterious effects. So it's looking at safety. We need to make sure that you meet certain criteria because then it makes it easier to evaluate, well, did this medicine really help you, or were you just not that sick and so it doesn't help you? And so there are certain criteria that we use to help determine if you should even get the drug. And by studying it in a regimented manner under criteria, we can look at those things such as safety, such as actual benefit, and not just giving you something to be giving you something. Did that help? Did that answer your question?
It totally did. Did I hear you guys say that you have some trials going on right now or some research on this going on?
Yes. I mean, essentially, all the patients that are getting this and other possible therapeutics for COVID-19 are all in a trial form. Yep. We're not just handing it out. I mean, we're doing this trial so we can keep up to date with clinical efficacy and safety and all those types of things.
Yeah, the key is to not have everybody just coming into it randomly, because then the information you get out doesn't make any sense. And so we do have certain, here's the selection criteria, here's the exclusion criteria. Now we can run with it, and then we'll see how you do, and we monitor you. So that's the trial's built like that, like most clinical research trials are. So we have 2 minutes. We have time for just 1 or 2 more questions.
Appreciate it. Thanks.
Hey, this is Dale Hogg. Dale Hogg, with the question follow up to
There was somebody who started just before you, Dale, I think. Just like if we have that voice, please.
Okay, no problem.
I'm sorry. Just really quick question. Cynthia Newsom, 41. Hey, how many healthcare workers do you know at your hospital there come down ill with coronavirus? And then what about, do you have a number of cancer patients that have come sick? And that's my last question.
Yep. So, and then Dale, we'll come back to you. So I think that the question about do we have healthcare workers who get sick? So because there's community spread, anybody can get this disease at any place. I'm not really at liberty to comment on specific healthcare workers, but we will all be affected by this, and healthcare workers are not different. What we do know is that in an environment using the right type of PPE, the risk of transmission to healthcare workers is extraordinarily low. Now, when they go home, they have the same risk you and I do, and that's really the fear around that. So around cancer patients, we want our cancer patient rate to be 0, because for those folks who have cancer, that clearly they're at increased risk for more difficult outcomes. The most difficult outcomes occur in people with chronic heart failure, chronic lung disease, and cancer, or chronic autoimmune disease, or people who are immunosuppressed like transplant. Those are the groups of patients we worry the most about. And so for those folks, we say, all that stuff about shelter at home, man, it makes sense for all of us, but it really makes sense for you. So as far as numbers of cancer patients, I don't know that we have a specific number right now, but it is something we monitor super closely. So Dale, you had a question?
Yeah, just a quick follow-up to the whole testing issue. Now, you guys are doing testing at the hospital. You're just not processing and getting assessing those tests.
Actually, we started processing the tests here at KU beginning on Monday, really Sunday night late, but Monday we had our first batch. And so we are now doing in-house both testing and processing, and we get the results all in-house. We've applied those to it was a small number to begin with as we ramp that up, but we're doing it for all of our inpatient COVID-19 concerns, because if we can get people out of the status of not knowing if they have it or not, then we don't drain the PPE. Otherwise, it's a drain while we wait to get those results back. And again, we've waited 3, 4, or 5 days.
So if someone walks into like the KU facility here in Great Bend, can they get a test there, or can they not?
Well, they can get the test there. The result has to be sent out, because they don't have the processing equipment there. Yeah.
Right.
Okay.
Yeah.
All right.
Okay. Okay, that's it then.
Thank you all very much for anything today.